Hi everybody, welcome to Dr Manny's YouTube Learn Shops. This is Understanding Cardiac Surgery for Nurses, Part 2, which just provides you with an overview. The overview deals with intraoperative procedures, cardiopulmonary bypass, surgical procedures, coronary bypass graft and valve surgeries, and other selected surgical interventions. And look, we just briefly look at cardiac transplant. Now, we have to look at sternotomies. Now, when we look at sternotomies, these are typically a vertical line, inline incision which is made along the sternum, after which the sternum itself is divided or cracked open. Incision for a median sternotomy is typically from the sternal notch to the linea alba, as demonstrated in the diagram. Then a sternal retractor is applied and the chest or the sternum is separated and the heart is exposed. You can also have mini incisions depending on the operation, and a lot of people are electing for mini incisions these days, keyhole surgery, faster healing, less trauma. With a mini incision, it typically has a reverse J incision or a C incision, or sometimes even a reverse or inverted L incision. Now, a mini sternotomy basically is a hemisternotomy, and this is a technique that basically aims to reduce operative trauma, accelerate your recovery time if you have the surgery, and improve the cosmetic, not such a big scar, outcome. The sternal retractor doesn't have to open the chest as far. And there are even smaller incisions that can be made. This is just an overview. Now, sternotomies can be partial, and they're becoming more common. Well, they are more common. They can be done on the right or the left side, or they can be para next to the sternum. And this essentially is minimally invasive heart surgery, also known as keyhole surgery. And this is when a conventional operation is performed on or inside the heart using much smaller incisions. Now, a pericardiotomy is important to note. Now, we've mentioned the pericardium, which we call the endocardium, previously in the introductory Learn Shop for this Learn Shop. And this is the surgical removal of a portion of the pericardium, endocardium, prior to cardiac surgery, or total removal of the pericardium for conditions such as constricted pericarditis, which we're not really discussing here today. However, it is cardiac surgery. So the pericardium is resected. The next stage during cardiac surgery is cardiopulmonary bypass. And this is a technology that allows cardiac surgical procedures to be performed in a quiet, motionless, static, bloodless surgical field, so the surgeon can see what he or she is actually doing. It incorporates an extracorporeal circuit to provide physiological support. Now, blood is drained from the heart and the lungs to a reservoir via a venous cannula and tubing, which we'll be looking at shortly, and then returned oxygenated to the arterial system by using a cannula, pump, oxygenator, or gas exchanger. Have a look at the ECMO Learn Shop. It discusses something similar to cardiopulmonary bypass. The cardiopulmonary bypass is typically used for short-term support measures, usually in hours, whereas ECMO, veno-arterial, arteriovenal, or veno-venous is typically used for days, sometimes weeks. Cardiopulmonary bypass was essentially first developed, as we mentioned previously, by Dr. John Gibbons. In the early 50s. When we look at the cardiopulmonary bypass circuit, essentially it consists of a pump and an oxygenator. There are cannulas inserted into the right atrium to take blood from the superior vena cava and the inferior vena cava. It pumps it to the oxygenator, which is the artificial lung, and then it allows it to be returned to the aorta. Blood is extracted from the atria, from the ventricles, to keep the heart static, motionless, empty, no air, no blood, so the surgeon can do what they have to do in relation to cardiac surgery. We have the patient, we have the SVC cannula that's inserted into the right atrium, right ventricle too. It's one cannula, keeps the heart empty. You can also have a cannula which is in the femoral vein. So you've got two cannulas to keep the heart empty. The blood extraction is controlled by the arterial pump, which keeps the blood flowing around the circuit, which again has got anticoagulation. There will probably be a heparin circuit or some other form of cannula anticoagulation if heparin is not indicated. The blood goes to the oxygenator, in this case the membrane oxygenator, the artificial lung, and then it's returned to the aorta, the aortic root, vent, reoxygenated. If we look at it in a little bit more detail, there's an aortic cross clamp, which means blood cannot come back past this point into the ascending aorta via the aortic arch. Blood again, look at the blue line, is extracted from the right atrium, right ventricle into a venous reservoir. The systemic blood pump is controlling how quickly blood is taken out of the circulation. There's also a suction pump, a venting pump, which keeps the heart essentially decompressed, empty of blood, no air, motionless. Then it goes to the gas exchanger and a heat exchanger because the blood's on its way back to the patient. So the blood is warmed to the patient's body temperature. The gas exchanger provides the function of an artificial lung, and then it returns via the arterial line red through an arterial filter. And look, there are lots of sensors, air detectors, thrombi detectors, hemoglobin detectors, etc. And it returns back to the aortic arch where it is now pushed out into the systemic circulation, head, neck, body. There's also an additional pump on most cardiopulmonary bypass circuits that allow cardioplegia to be infused, antegrade and retrograde, meaning that the cardioplegia actually goes to the heart. And this is a solution, which we'll be discussing, that now keeps the heart in a stage of arrest, quiet, but oxygenated as well. Now, when we look at venting catheters, a venting catheter is essentially inserted into the right atrium, right ventricle, and blood is drawn into a reservoir, and a pump is used to extract the blood from the reservoir into an oxygenator, which is the artificial lung. And this is where oxygen is added and carbon dioxide is removed. The aortic root cannula are essentially, in some cases, intended for antegrade delivery of cardioplegia solutions, also the venting of the heart and to aspirate air from the aorta prior to concluding the cardiopulmonary bypass. You don't want the heart to have any air in it, otherwise they'll get an air embolism and they could possibly have an embolic phenomena occurring and stroke. The brain has to be protected. And cerebral protection basically is hypothermia. And hypothermia in the literature has become a foundation for cerebral protection during cardiopulmonary bypass and is balanced or applied to counterbalance the harmful effects of oxygen deprivation on the brain. And as you can see in the diagram, hypothermic oxygenated blood is perfusing the brain via the right subclavian artery, because there's a clamp on the SVC as well. Then deoxygenated blood is returning to the heart via the carotid artery and the inferior vena cava. Hypothermia typically is from 18 to 24 degrees centigrade to provide cerebral protection. It also decreases metabolic requirements for the heart. Then you've got myocardial protection, and this is a combination. You've got cardioplegia and you've got hypothermia 18 to 24 degrees. And this causes myocardial paralysis, well, the cardioplegia does. And cardioplegia basically consists of 3 parts blood and 1 part cardioplegia. And this is a hypokalemic, hypomagnesiemic solution, and it's infused at about 3 to 4 degrees centigrade. And it's typically retrograde through the superior vena cava into the right atrium, and also retrograde via the coronary sinus. The aims are to preserve myocardial function in a bloodless and motionless operating field, because sometimes it isn't as effective as it could be, because the patient, after the surgery, has come down with a stunned myocardium, which basically means there's an element of ischemia, but hopefully no myocardial ischemia that has caused infarction. Hypothermia and cardioplegia protect the heart from ischemic injury during cardiopulmonary bypass. Blood cardioplegia has, as we indicated earlier, a dedicated pump on most cardiopulmonary bypass machines, which controls the infusion rate, the temperature, and blood mixing ratios for the cardioplegia. We said 1 in 3. Now, some of the surgeries that we'll look at include 1, coronary artery bypass grafts, CABGS. And this is when blood vessels, as grafts, are used for coronary artery bypass procedures, and they consist of sections of a vein for the leg. These are saphenous veins, greater and lesser, or an artery in the chest, left or right internal mammary, or sometimes even the radial artery. The vein or artery graft is attached above the coronary artery blockage, obstruction, and the other end below the coronary artery blockage, obstruction. Blood bypasses the coronary artery blockage by going through a new graft to reach the heart muscle. The indications for coronary artery bypass graft surgery are a stenosis of a coronary artery more than 50%, left main coronary artery disease, which means left anterior descending artery, triple vessel disease, right coronary artery, left coronary artery, and circumflex, double vessel disease, right coronary artery and left coronary artery, symptomatic problems with the patient despite being on maximal medication therapy. The graft harvest sites include internal mammary arteries, splenic artery, the gastroepiheliac artery, and the radial artery. But typically the most common ones are left internal mammary, right internal mammary, and radial artery from an arterial perspective. Left internal mammary arterial graft. This one is to the left anterior descending coronary artery, coming off the left subclavian artery. Then you've got venous harvest graft sites. And typically the veins can be the basilic vein, cephalic vein, lesser saphenous, greater saphenous. But the most common ones are the lesser and greater saphenous veins. And this is an example of the saphenous vein graft to the right coronary artery and to the circumflex artery. And as you can see, the grafts have been sutured or conjoined to the ascending aorta. High pressure system allows the grafts to direct blood into the coronary artery. However, the surgeon has to be very, very careful. Remember, saphenous veins have got valves. So the valves have to be going in the right direction, otherwise there'll be no blood flow. Now, what are some of the complications associated with CABGS or coronary artery bypass graft surgery operation? Bleeding, atelectasis, pain, you can have a stroke, graft closure, you can have cardiac dysrhythmias, the wounds can get infected, especially if you're a diabetic, healing problems in the same circumstances, you can go into renal failure, you can develop a gastrointestinal ulcer as a result of ischemia. Complications can be under the headings of infectious, cardiovascular, gastrointestinal, respiratory, neurologic, immunologic, and renal. We've mentioned the most important ones, but there are numerous complications that occur following coronary artery bypass graft surgery. Now, the prognosis for coronary artery bypass graft surgery is pretty good, actually. So, post-surgery, typically 5 years, but it seems to be greater. Revascularization surgery, 66% of cases. There's a greater survival if you have an arterial graft versus a venous graft. Age, the older you are, the more risk you are. Women, for some reason, seem to have more comorbidities. And cardiopulmonary bypass, if you go into cardiopulmonary bypass, not off pump, you can have more comorbidities in the future. When it comes to surgery for cardiac valves, valve surgery involves invasive procedures during which the cardiac surgeon may need to trim, reshape, or rebuild or replace the diseased valve. So it can be replacement or it can be repair. The aortic valve is the most common valve to be replaced. Why? Probably because it works the hardest in our lifetime. It's in a high pressure systemic circulation. It's got to work pretty hard. The mitral valve is the most common valve to be repaired. It's on the left side of the heart as well. It has to work pretty hard as well. Only rarely is the tricuspid valve or the pulmonic valve repaired or replaced, and more so probably in children. During valve repair surgery, a ring is placed at the base of the heart valve to provide added support to the repaired valve, and this procedure is typically referred to as an annuloplasty. Now, an annuloplasty is basically cardiac valve repair. In an annuloplasty, the surgeon tightens or replaces the ring around the valve so that the valve leaflets can close properly. An annuloplasty rings restore the cardiac valve to its normal size and shape, as the valve is often enlarged or distorted in that diseased state. Regurgitation, stenosis. If left untreated, the valve regurgitation can lead to congestive heart failure and irreversible heart damage. If a valvuloplasty, which is cardiac valve repair, done via a balloon. So valvuloplasty is also known as balloon valvuloplasty. And this is a non-surgical procedure, which I'll just mention, that widens the heart valve that is narrow. Valve stenosis forces the heart to pump harder to get enough blood through the valve, and a narrowed heart valve has leaflets that become thick and stiff and fuse together, causing stenosis. And typically, the valves that are repaired by this method are the aortic and mitral. Now, when it comes to valvectomy, cardiac valve replacement, this involves removing a faulty or damaged valve, replacing it with a new valve made of synthetic materials or animal tissue. This can be a mechanical valve or a biosynthetic valve, or it can be a xenograft. The aortic valve is the most common valve, as I mentioned previously, to be replaced. The mitral valve is the most common valve to be repaired. Rarely is the tricuspid valve or pulmonic valve repaired or replaced, other than in congenital heart disease. Now, mechanical cardiac valve replacement. These valves are typically made of carbon and metal. There are three basic types of mechanical valve: bileaflet, monoleaflet, and caged ball valves. The main advantage of mechanical valves are that, look, they last forever, I guess, but they can break. They can be faulty. But they're less likely to need replacing and therefore are often better suited for younger people. Because if you're young, you're going to have to come back and have another operation, another operation, another operation, another operation, if it's maybe a biosynthetic valve. Mechanical valves can last a lifetime, but they come with increased risks of thrombosis and bleeding, as well as the need to take an anticoagulant, which will be typically warfarin. Now, the advantages are that they're long-term. The disadvantages are that you require anticoagulation. And even so, thromboembolic phenomena can occur and you can bleed. And the valves can cause red blood cell damage, hemolysis. They're not gentle like your God-endowed valve. Cardiac valve replacement, as I said, these valves can be monoleaflet, bileaflet, or a caged ball. Then you've got biological tissue valves. These are bioprosthetic valves that are generally either made of bovine, cow, pericardium, or porcine, pig, aortic valves, but may also be produced from horse, equine, or pig, porcine, pericardium. These are called xenografts. They come from animals. Tissue or biological or bioprosthetic valves, also made from human tissue, are called homografts. And all these valves have been treated typically with antibiotics and products to prevent rejection by the body. Biological tissue cardiac valve replacement. What are the advantages? Anticoagulation is uncommon. There's no hemolysis, and the incidence of thromboembolic phenomena is low. The disadvantages are, however, they don't last forever. Their durability is limited. They require subsequent replacement, which means you're going to have another operation. And with every operation that you have, there's an increased risk of developing a problem. Now, the post-valve surgery complications are numerous. It can be hemorrhage, thromboemboli, mechanical valve thrombosis, paravalvular leak, dehiscence, hemolysis. You can have deterioration of the structure of the valve. You can develop infective endocarditis. And look, even though the valve's been matched to you, it may end up being either too small or too big for you to use. You can develop mediastinitis, sepsis, failed repair or replacement, myocardial infarction, congestive heart failure, tamponade, stroke, acute renal failure, even probably respiratory failure. The prognosis after valve surgery, however, isn't too bad. The average life expectancy after heart valve replacement surgery ranges from 16 years for people 65 or less to about less than 10 years, 6 or 7, for those over the age of 75, which the statistics aren't too bad. 10 years after surgery, most people, 94%, still have an effective valve, survival rates being influenced only by their age and their general health. So, As far as valve surgery goes, aortic valve replacement surgery, more than 94%, 5-year survival, 10 years, 84%. That's pretty good. 64, 37% mitral valve replacement surgery, 96, 93 pulmonic valve replacement surgery, 79, 49% tricuspid valve replacement surgery. Now, when we look at selected miscellaneous surgical procedures, I've just chosen these. The BENTALL DeBONO procedure, which is for aortic root and aortic valve replacement. The Ross procedure, which I mentioned previously in the historical highlights. The pulmonary valve, which is an autograft coming from the same person, patient, replaces the aortic valve. Then you've got the Mays procedure, which there are numerous for. I've just chosen a general view, and this is done for atrial fibrillation. So when we look at the BENTALL DeBONO procedure, this is aortic and aortic valve replacement. And essentially it replaces part of the ascending aorta and aortic valve because the heart has an aneurysm in the aorta, the ascending aorta, as you can see in the diagram. And typically it's resected, the coronary arteries are reimplanted, into the graft. And then you end up with a neo-aorta, or new neo, ascending aorta, and valve. The coronary arteries are implanted. The BENTALL DeBONO procedure. Then you've got the Ross procedure. And the Ross procedure is the pulmonary valve, an autograft, replaces the aortic valve. So the Ross procedure is performed on patients typically aged 40 to 50 who don't want to take long-term anticoagulant medications after surgery. It's also known as the switch procedure, and this is where the diseased aortic valve is replaced with the patient's own pulmonary valve as a homograft. Now remember, God didn't create the pulmonary valve to work in the aorta. But it's an effective procedure, as you'll see. So step 1, typically the surgeon will measure the aortic and pulmonary valves. Step 2 will be the aorta and pulmonary artery are opened and the aorta and pulmonary valves are carefully inspected to determine if the Ross procedure is an appropriate procedure. Step 3, if it is, the diseased aortic valve is removed, then the pulmonic valve autograft is removed and placed in the aortic position. So the pulmonary valve becomes the aortic valve, the new aortic valve. Step 4, the autograft is sutured in place and the coronary arteries are reattached to the new aorta, which is the pulmonary artery root and valve. Step 5, a pulmonary homograft is attached to the right ventricle outflow tract. Step 6, the aorta is attached to the autograft and the pulmonary artery is attached to the homograft, and the procedure is complete. Then we have the Mays procedure. The Mays procedure is a surgical treatment for atrial fibrillation, and it's also referred to as, or known as, surgical ablation. For symptomatic atrial fibrillation where catheter ablation has failed, and for those patients with a history of stroke or thrombotic emboli, this procedure has got many variations, and I'm just going to give you an overview. It can use small incisions, radio waves, freezing, which is cryogenics, microwaves or ultrasounds to create scar tissue. The purpose is to create scar tissue. So if we look at an external view of the Mays procedure, the atrial appendages are resected because they're considered to be a potential arrhythmia source. So they're removed. The internal view that you see are the atrial appendages are also resected because they're a potential arrhythmia source. So you'll see a suture line. Left atrial appendage, you're in the left atrium. The left atrium is commonly the more common site for dysrhythmia, atrial fibrillation origins, rather than the right atrium. But it can be the right atrium as well. Then, the left pulmonary veins, right pulmonary veins that you can see, the external view, the pulmonary veins are incised, so therefore they're cut around to create scar tissue because they're a potential arrhythmia source as well. So when you look at the internal view, you can see the white lines, they're the incision lines made by the surgeon. The pulmonary veins are incised, then they're reconnected, but there will be scars as it heals. So what you end up seeing then is the Mays ablation mediations, scar tissue, blocks the abnormal conduction pathways. And these are generated within the atrial appendages and around the pulmonary veins. So therefore, we pray that the heart continues its normal conduction through its normal pathways. Because the scar tissue sort of redirects the electrical current from the SA node through the atria to the AV node, through the fibrous skeleton, through the pathways into the ventricles. So that we end up having, God willing, normal conduction. SA node, AV node, Ispikhinji system. Now, I've selected specific congenital cardiac anomalies just to give you an insight and the surgery that's related to it. If you want more detailed information, look, go to the Dr Manny Congenital Anomaly Learn shops and this will give you more insights. Persistent ductus arteriosus, PDA. This is a persistent opening between the aorta and the pulmonary artery and is a normal part of the fetal circulation as the ductus arteriosus. However, after birth, typically 24 to 48 hours, sometimes 72 hours, sometimes longer, it closes. But if it remains open, it's called patent or persistent ductus arteriosus, PDA. Now, treatment is typically ligation, which is really just open chest surgery, or dissection, which is open chest surgery as well. They are two options as surgical interventions. There are other interventions. Then you've got coarctation of the aorta and its repair. Now, coarctation of the aorta is a birth defect in which part of the aorta is narrow, and if the narrowing is severe enough, the baby will have serious problems. End-to-end anastomosis is one option as a surgical intervention. And there are lots of interventions that can occur, but I've chosen this one just to demonstrate. The coarctation of the aorta is a problem ongoing until the child reaches adulthood. And even then in adulthood, it can be problematic. Atrial septal defect repair. This is a birth defect of the heart in which there's a hole in the septum that divides the atria right and left of the heart. The hole can vary in size and may require surgery which places patches that cover the hole on both sides of the atria, left and right sides. Atrial patch repair. Then you've got ventricular septal defect, which is probably the most common congenital defect worldwide. And a VSD, ventricular septal defect, is a birth defect of the heart in which there's a hole in the septum that separates the ventricles of the heart. Typically, a patch of synthetic material is used, but pericardium can be used as well by the surgeon to close the ventricular septal defect. The surgeon uses suture material to suture the patch in place, and God willing, everything's okay. Tetralogy of FALLOT. Tetralogy of FALLOT is probably the most common cyanotic congenital cardiac anomaly, and it's a birth defect that affects normal blood flow through the heart. There are 4 congenital heart defects, tetra, which include a ventricular septal defect, pulmonary stenosis, a misplaced aorta, which is called an overriding aorta, and right ventricular hypertrophy. Surgery involves closure of the VSD, ventricular septal defect, and widening of the pulmonary trunk with a dacron or pericardial patch. Dextrotransposition of the great arteries in the repair. Well, this is a birth defect in which the pulmonary artery and the aorta are switched in position or transposed. And this is potentially life-threatening unless there's a shunt of some kind, which means if the baby is born with an ASD, VSD, AVSD, a patent ductus arteriosus, then it won't die straight away. However, if it's not, it'll die straight away. So, this is now a defect where the pulmonary artery and aorta are switched in position. The aorta receives only deoxygenated blood, and the pulmonary artery only receives oxygenated blood. If there's a shunt, ASD, VSD, PDA, AVSD, then there's mixing of arterial and venous blood, and the infant can survive with medical intervention. An arterial switch is the surgical procedure that is most commonly done these days as the main treatment to correct DTGA, and it's also called the Jatin repair, which you can review if you choose to, as I said in the Learn trips on congenital heart disease and the interventions. Then you've got the atrial switch, which was the most common procedure before the Jatin repair. And this is the setting or mustard repair, and this uses a baffle, which is typically tissue baffle or now synthetic material baffle, which redirects blood from the right side to the left side and left side to the right side. But it's really complex. It causes potential trauma, and it isn't really favoured these days by cardiac surgeons. The arterial switch, however, what it does, it now switches the pulmonary artery back to its original position, but it uses the aortic valve for the pulmonary artery, and the aorta goes back to its original position, but it uses the pulmonary valve. But it creates a new aorta, a new pulmonary artery, a neo-aorta, and a neo-pulmonary artery. This is the arterial switch, also known as the Jatin procedure, after the surgeon, Dr. Jatin, who was South American, I believe. Have a look at the congenital cardiac anomalies lecture, and you'll see all that. Then you've got the truncus arteriosus, or now commonly referred to as common truncus and repair. The truncus arteriosus, also known as common truncus, is a rare defect of the heart. The aorta and pulmonary artery are typically single vessels. However, in this situation, they're merged into a single common blood vessel coming out of the heart, and the procedure is typically done using the Rastelli repair because it's usually more complicated than just the common truncus. There's usually a VSD or some sort of other shunt problem or some sort of other problem related to the valves. And in this procedure, the right ventricle and pulmonary artery end up having a valve conduit. The VSD, ventricular septal defect, is patched. Now, cardiac transplant, this is just a brief overview for completion. And this is a heart transplant, which is a surgical procedure performed on patients with end-stage heart failure. They have severe coronary artery disease, or it's done when other medical surgical treatments fail. It's a last resort. Now, the indications are end-stage heart disease, and the New York Heart Association heart failure states stage 3 and stage 4 are indicated. And this is related to non-ischemic cardiomyopathy, idiopathic cardiomyopathy, valvular heart disease, congenital heart disease, or myocarditis. Some of the congenital heart disease is really severe. You should have a look at the congenital cardiac anomalies Learn. Very interesting. When you look at the New York Heart Association class level indications, stage 3 essentially is marked limitation of physical activity. You're comfortable at rest, but less than ordinary physical activity results in shortness of breath, fatigue, or cardiac palpitations. 4 is you're unable to carry on any physical activity without discomfort. The symptoms at rest can be present, so you're not doing anything, and you're short of breath, fatigued. If any physical activity is undertaken, the discomfort gets worse. The New York Heart Association classes level of clinical impairment. They're the ones, 3 and 4, that are indicators for potential cardiac transplant. So what happens with cardiac transplant then? Well, you've got stage 1. And in stage 1, the recipient heart is transected from the superior vena cava and the inferior vena cava, the pulmonary and aortic root, and the posterior wall is left, so the atrial wall remains with the pulmonary veins. In stage 2, as I said, the recipient posterior left atrial wall is left, but it's sewn onto the donor resected left atrium. They're joined. In stage 3, the donor's right atrium is connected, therefore sewn, to the recipient's superior vena cava, inferior vena cava, aortic and pulmonic root. It's like doing a jigsaw puzzle, I guess. Joining the dots. Donor to recipient. The donor's heart is joined to the recipient's superior vena cava, inferior vena cava, aortic and pulmonic root. Because it's the heart that needs to be replaced, not the great vessels. Then in stage 4, the cardiac orthotopic allograft is complete. Orthotopic just means the heart is actually replaced. You've got other types of cardiac transplant where the donor heart is actually joined to the recipient's heart. But orthotopic basically means the recipient's heart is removed completely. The donor's heart is joined to the great vessels. So you can see the donor's heart is joined to the recipient superior vena cava, inferior vena cava, aortic root, and pulmonic root. So let's review. Can you name the coronary arteries of the heart? You can? Good. You've got the right coronary artery, the left coronary artery, the circumflex off the LAD, and you've got the marginal branches. And you have diagonal branches. Can you label the following structures of the heart in your mind, which are blank in the following diagram? Have a look. Okay. You've got the aorta, the pulmonary artery, the left atrium, right ventricle, left ventricle. Nothing hard about that. Can you identify and name the 4 cardiac valves? Again, nothing hard about this. You've got the pulmonic and aortic, and mitral and tricuspid. Tricuspid, 3 cusps, mitral, 2 cusps, aortic, 3 leaflets, pulmonic, 3 leaflets. The aortic valve is always connected to the coronary arteries, right and left, at the sinuses of the valsalva. Name the typical arterial harvesting graft sites for coronary artery bypass graft surgery. They are right internal mammary, rema, left internal mammary, lima, and the radial artery. Okay, can you name the typical venous harvesting graft sites for coronary artery bypass graft surgery? We said basilic and cephalic veins. However, the more common ones are from the legs, the lesser and greater saphenous veins. Can you name common designs of mechanical cardiac valves using the following diagrams? Not the names of the valves, but the common designs. They are the swivel tilting disc design and the ball and cage design. What about the common types of biosynthetic cardiac valves using the following diagram? Well, these are allografts and xenografts. Both come from different species. Remembering, homografts are from human beings. The same human being who is the patient. Name the vascular defect and the corrective surgery in the following diagrams. What's the defect and what's the surgery? The defect is coarctation of the aorta, and the corrective surgery in this situation is an end-to-end anastomosis. Can you name the cardiac defect and the corrective surgery in the following diagrams? What's the defect and what has been done to correct the defect? The cardiac defect is a ventricular septal defect, VSD, and the corrective surgery is a patch closure of the VSD. Can you name any 4 medications which we haven't discussed yet that a patient may require post-operatively in the cardiac surgical intensive care when they are transferred from the OR, the operating room or theatre or suite? The medications would be vasoactive, epinephrine, dopamine, dobutamine, norepinephrine, vasopressin, prostaglandin E2, glyceryl trinitrate or nitroprusside, and most importantly, oxygen. Okay, thanks. This is the end of part 2, Understanding Cardiac Surgery. If you found this of any benefit, please recommend it to your colleagues, subscribe if you choose to, and most importantly, conclude part 3, Understanding Cardiac Surgery for Nurses. See you next time.